So Maria, I will share the posters.
Okay. Sounds great. Thank you. I thought I was going to be responsible for that, but that's wonderful. So you're going to handle the recording part and sharing screen.
Yes.
Okay.
I'll try my best.
Okay, I'm here for backup also. And just in terms of order of the presentations, it'll be Sarah Garrett first, and then Kayla, followed by Fiona, and then Celestine. Okay, let's give folks just another minute and then we'll get started. All right, my Zoom screen filled up, so I'm going to take that as a sign. We have a quorum to get started. My name is Maria Chow. I am an associate professor at the Osher Center for Integrative Health and also DGIM at San Francisco General. I'll be facilitating the session today. Our short oral presentations focused on racism and implicit bias in perinatal and neonatal care. Each of our 4 presenters will have about 5 minutes for presentation. Folks, please do feel free to put Q&A in the chat. We'll also have an opportunity to interact. These are a little bit more informal, smaller groups than the webinar big sessions. I also want to invite folks to turn video on if that's comfortable, if you're in a place where you're able to do that, just to support our presenters and hopefully facilitate our own engagement as well. All right, also want to thank Angeline for all of the amazing support from the past 2 days, and we're also lucky to have her in our session today, providing support around recording and sharing screen. Any other housekeeping things, Angeline?
I will help with muting people if need be, or muting them, or putting them away if they need be. So I'll try to do that. And please just let me know if I need to move around the your poster. This is my first time helping with this, so bear with me. I'll try my best. And I'll keep myself on no on mute and also no video, but I'll be here.
Sounds good. All right, so first up we have Sarah Garrett, who will be presenting on clinician implicit bias training. Sarah, the stage is yours.
Thank you so much, Dr. Chow, and good morning, everybody. All right, I'm going to get my own notes pulled up here.
Please let me know if we're able to see the poster. I did the sharing.
Yeah, I can see it great. And,
perfect.
You know, it's fine to me if you want to keep it as it is, or if you want to focus on the left panel initially, left first initially, and right part.
Okay.
Totally up to you. I know people can download this as well.
Okay, great.
So thank you so much. I'm really excited to present this research with everyone. Before diving in, I would love to acknowledge my collaborators. This is an interdisciplinary team, which includes socio-legal scholars, academic researchers, aspiring med students, and also community collaborators, Breezy Powell, Linda Jones, who is also a co-investigator, and Julie Harris, who have guided the project at every step of the way. So in 2019, and also we have no disclosures to report, and we're grateful for our funders, the California Preterm Birth Initiative and NIH and AHRQ. In 2019, California passed Senate Bill 464, SB 464, which requires that hospitals and alternative birthing centers provide implicit bias training to perinatal clinicians. And lawmakers designed this law specifically with the goal of improving clinical outcomes for Black women and birthing people. But it's unknown whether implicit bias training will affect these outcomes, and it is not known what approaches would maximize its impact. So we knew we had to go to the people who are going to be most affected by this policy to understand, what's next. So we launched a study to engage the insights of key stakeholders, the Black women and birthing people who were supposed to benefit from this policy, and the perinatal clinicians who would have to take the training in order to understand key challenges and opportunities for effective clinician implicit bias training. We conducted a mixed methods community-based participatory research study in the San Francisco Bay Area. This involved focus groups with Black women and birthing people. Actually, specifically, everyone in the focus groups identified as Black women who had a hospital birth. There were 20 of them. And then in-depth interviews with multidisciplinary hospital-based perinatal clinicians, 20 of them, which included certified nurse midwives, RNs, MDs, and others. We conducted inductive and deductive thematic analysis and member checking, and I'm happy to get more into our methods during the Q&A. Our overarching finding was that patients and clinicians had concerns about clinician implicit bias training, but that they supported its use and identified numerous ways to maximize its effectiveness. Specifically, 19 of the 20 focus group participants wanted their own providers to take implicit bias training, and many clinician participants described it as important and were hopeful it will change care and outcomes. There were robust challenges described, which I'm not going to actually get into since we don't have much time today. I'm going to focus on the recommendations that our respondents identified. So we categorized these on 4 levels, and there was a lot of overlap. Certainly, in what levels people recommended change and improvements, but also recommendations even within those categories between the patients and the providers. So we present them here together today. So again, I'm going to skip over the challenges section and focus on recommendations. So thinking about how to optimize implicit bias training for birth equity, for improving care and clinical outcomes for Black women and birthing people. Recommendations focused on the level of policy, needing clear and effective enforcement mechanisms, expanding the scope, intensity, and funding of implicit bias training, mandating implicit bias training for the entire healthcare workforce. On the level of training, recommendations centered on enhancing content, for example, customizing the training to the facility, involving real patient stories, which Fiona will talk about, including information about the history of racism in medicine, using interactive training formats, and supporting practical and applied anti-bias skills building. On the level of the learners themselves, the idea of engaging training seriously and with an open mind, and being open about recognizing one's own biases. There's some great quotes about that in the middle panel. And then regarding the healthcare facilities themselves, creating accountability systems for implicit bias training and for reductions in biased care. That was particularly important to our patient respondents. There's my time, I can tell. And then fostering safe spaces for learning and discussion, easing logistics, implementing complementary interventions such as healthcare workforce diversification. And I really want to emphasize that point. Many of our respondents said implicit bias training, as we all know, cannot itself change all of these outcomes, it has to be complemented with other structural changes. So finally, there are numerous challenges to implicit bias training improving care and clinical outcomes for Black women and birthing people. Stakeholder-informed insights are crucial to the development and implementation of health equity interventions, and we hope that lawmakers and health system leaders would leverage insights like this in implementation and policymaking decisions, and we're currently working on getting these out to those decision makers. Thank you very much.
Thank you so much, Sarah. That was amazing. A whirlwind, jam-packed with information. I want to open it up to the group for questions. I'm thinking we could take about 2 or 3 questions before moving to the next speaker. Also thinking that there is so much cohesion between the 4 speakers and the topic. I'm looking forward to engaged discussion at the end as well. So, questions that are coming up for Sarah. I will throw one out there. I was wondering, I'm very heartened that there was a policy. Actually, go ahead, Ade.
Hi, my name is Ada, and I work in the NICU at Children's Hospital in Oakland. Hi, Sarah. I actually do brave spaces in the NICU, and I know another unit of our hospital is doing them. I wondered twofold. I wondered in one part, the participants that did go through the DEIAR training, did they have an exit questionnaire, like within a week, to follow up how they felt about the training, what changes they've implemented in their own, maybe personal thoughts, bias, or the way they work, with their patients. And then 2, in terms of the, pretty much a statement in terms of the brave spaces, what I have found in doing them in my unit is that most people want to have information given to them, and very few want to speak up. Maybe because of the unit being so close and management is involved, and sometimes it's more difficult for them to express their feelings about what's going on in the unit. That's just an observation that I've had in having these brave spaces.
Yeah, thank you so much. In the data collection we did with clinicians, with providers, no one mentioned to me that they had a follow-up survey like that, but we did ask them to reflect on changes they observed in themselves or their colleagues following different interventions. This is obviously the implicit bias training mandated by SB 464 is not the only anti-bias or anti-racism interventions going on in these spaces. And so we can't really pinpoint it if it's a given thing. But we do have some data on what people are seeing in terms of changes or how they themselves have changed some of their behaviors. And regarding the brave spaces, and I think that's such a wonderful term, some people did say brave spaces instead of safe spaces. But I think you're getting at attention that a lot of our respondents articulated as well, which was that there's this important thing going on where clinicians, providers need to be able to talk with each other about difficult topics in order to change the culture, but it's also very risky in some cases to do so. And so sometimes it's easier to work with outside people on this rather than inside people. And I think that's a really interesting and naughty challenge for us all. Thank you.
Thank you.
Other questions for Sarah?
Hi, Sarah. Really wonderful work. I have more of, I guess, a research methods question. I was just wondering if you could comment on how inclusion of your community collaborators affected and potentially changed the way that you approached this project and your findings.
Yeah, excuse me. I mean, I would find it hard to articulate any one effect. I feel like they enriched the entire project. We had 4 individuals from the start. Halima Fayusuf is an author here, but had to step back, so she's no longer on the advisory board. But from the beginning, the advisors led discussions about which sites we would approach, how we would frame our asks, Linda Jones, co-investigator and lead community advisor, ran the focus groups. Together, we all developed the data collection guides, and we decided what to prioritize in terms of where were we going to disseminate information first. The design of a lot of the posters and our presentation materials come from Breezy in particular. So, I mean, their contributions are really throughout the project, and
Yeah.
it would be we would have, I think, had less reach and produced less impactful science if they had not been involved.
Yeah, thank you. You can tell from your presentation of it. So thanks for sharing.
Thanks. It's nice to see you.
All right, we will have more opportunity for discussion towards the end. For now, let's move to our next presenter, Kayla Carvonen, who will be presenting on operationalizing structural racism.
Hi, everyone. My name is Kayla. I'm a third-year neonatology fellow here at UCSF, and I will be speaking on structural racism and how it's operationalized via adverse events in our NICU here at UCSF. I'd also like to acknowledge the multidisciplinary team and community advisory board, without whom this work would not be possible, as well as the UCSF NICU for funding and supporting our study. So we all know that racism impacts health and health outcomes, specifically structural racism, or systems, institutions, and hospitals have discriminatory laws, practices, and procedures that are both historical and in the present that have resulted in a disparate distribution of goods, services, and resources for racialized groups. We know that there are disproportionate experiences regarding toxicology screens, CPS referrals, and policing while hospitalized for minoritized individuals. And so we wanted to operationalize structural racism by examining adverse events in our NICU. And so we looked at our retrospective cohort study data of 3,290 infants who were hospitalized in our NICU between 2017 and 2019 through the REJOICE study. And we examined both demographics and adverse events, including infant urine toxicology screening, CPS referrals, behavioral contracts, and security emergency response calls that we found by collecting through electronic medical record data. And we chose those adverse events as recognizing them as decisions made by clinical teams that are difficult decisions that are made with the intention of promoting a safe hospital and home environment, but also have can result in significant harm or unwanted by all parties and largely should be avoided. And we know that these types of decisions are difficult to make and are decisions in which implicit bias may be playing a role. So we conducted logistic regression models to test the association between race and ethnicity and adverse events controlling for length of stay, as we know that the longer that families are hospitalized, the more likely they are to have these types of events. And we compared our racial and ethnic groups to a white referent group. We are looking at all infants who were hospitalized between 2017 and 2019. So in our NICU, many babies are preterm, 40%. Many families have had prenatal care, most have, and families stay for an average of 19 days in the hospital. Most families have babies who are born inside UCSF hospital, and most families are white, Latinx, or Asian in our NICU. And 8% of families are identify as Black in our NICU. And most families speak English as their primary language, but about 10% speak another language other than English, and most families had public insurance. And overall adverse events that we measured were uncommon. 6% of families experienced an adverse social event, so 205 out of the 3,290 families. 3% experienced a CPS referral, around 1% experienced a behavioral contract or a security emergency response call, and 5% had a urine toxicology screen. And the persistent finding that we found across all adverse events was that Black families were more likely to have all of the adverse events, and we're overrepresented despite comprising almost 8% of the sample size. Black families had experienced 65% of the behavioral contracts, 23% of the CPS referrals, 38% of the emergency response calls, and 18% of the urine toxicology screens. And in our logistic regression models, you can again see that Black families are more likely to experience all adverse events across the boards. So CPS referrals, behavioral contracts, emergency response calls, and urine toxicology screens. And American Indian, Alaska Native families are also more likely to experience CPS referrals, urine toxicology screens, or any adverse events compared to white families while controlling for length of stay. So this study is, just our center, a single center study that may or may not be generalizable although I don't believe that these findings would be unique to our institution given historical data and information that we have. The adverse events were uncommon, and so they were rare events, and so the estimates of our multivariable analysis were unstable and the confidence intervals are wide, although the trends seem to be persistent and consistent throughout our study. We looked at documentation of these outcomes, which is not a direct measurement of the outcomes, but in overall, we found this consistently that Black and American Indian, Alaska Native families were more likely to have these adverse events. And our study was really a humble inquiry. It was not to generate blame, but to critically evaluate how we as providers and hospital systems may perpetuate interpersonal and structural racism and contribute to racial disparities. And so this study really prompted deep internal reflection at our center. And we believe that we should all take part in this process for health equity, and that these types of methods can be a model for other centers to interrogate their data and support action to promote anti-racism and racial equity. And so we're sharing our findings with the Community Advisory Board of Black and Latinx families who have spent time in our NICU to discuss and direct interventions. And this is a unique model instead of a top-down approach of how we should do things differently, really asking the community to help direct our interventions as they bring their lived experiences to the table. And so future studies will be needed at other NICUs too to interrogate their local data to support action for anti-racism and racial equity.
Thank you for that powerful work, Kayla. Questions for Kayla? Go ahead, Ade.
Wow, I'm so impressed with the work. And that's really what I wanted to say. I work in the NICU, like I said, so how can we be involved in this kind of study? And we have a large population in the NICU, both Latinx, African American, and being a part of it and knowing the insides of what happens and working in the brave space, it's really insightful. And how can we be a part of that?
Yeah, you're at Children's Hospital Oakland, correct? Yeah, I would love for us to partner. I've started to start to ask that question, how we can partner together, because I think we should be doing this work at across the bay at both institutions. And I think there's a lot to be done. It's sort of opening a lot of different topics and ways that we could intervene at both NICUs. And so there's plenty of room and opportunities for us to work together. So I would really look forward to expanding this work beyond our institution.
Mm-hmm. Even expanding or in your advisory board, including, parents from our unit. And so then we don't have to duplicate things, but just, bring in and increase the numbers too. So each unit is run differently, dynamics are different, but the bias and the anti-racism that we want to explore is the same in a way, you know.
Totally, completely agree. I think there's opportunities, and that's why we want to really share and build this work. Is I don't think this is unique to our center, but we can share what we learn from our work to inform other institutions too. And so I think that's a really, really important part of this work, is sharing and collaborating.
Yes, thank you.
Let's take Sarah's question and then we'll move on to the next presenter.
Thanks for this interesting work. Just a quick question around, I know you're in the process of sharing this back with your advisors and stakeholders. I wonder what you've heard so far. What are some initial reactions you're getting and maybe ideas?
Yeah, we've had one event so far, one session. We have a few planned for this year to go through all of the results of our study, but we did have a chance to share this specific information to our community advisory board about a month ago. And there's a lot of themes that come out mostly around just humanism and humanity, really thinking about respect and being heard is really key themes from our unit. And, I think that's a really like basic need is like when you have your child in the NICU, I think what you need as a parent is to be understood and respected and heard as just like basic levels of care. And I think that I think that's very doable and intervenable. And so, yeah, thanks for that question.
Thanks so much. All right, Fiona Miller is our next presenter, and we'll be sharing about patient stories and the role of reducing bias.
Thanks, Dr. Chow, and thanks everyone for joining today. My name is Fiona Miller. I am a fourth-year student in the School of Medicine, applying to OBGYN residency. And I am going to present on a subset of the data from Sarah's study that you have already heard about. So I have the benefit of going second, but I had the privilege of joining this project sort of late in data collection. And so I'm not going to recap the framework of the study since you've already heard about it. But I've been working with Sarah and one of my classmates, as well as some members of the advisory board, to look at some themes that came up in the data that were really compelling to us, that we felt were worth pulling out and looking a little bit more closely at. So that's what I'm going to talk about today. So in the interviews with clinicians that Sarah and her team were doing, a theme that came up that wasn't prompted by the study guides and sort of arose spontaneously was clinicians' recommendations for real patient stories to be included in implicit bias training. And this came up enough times that it, something that was noticeable. It ultimately arose independently in 15 of the 20 clinician interviews. And clinicians talked about patient stories being incorporated into implicit bias training. And then some also talked even more specifically about stories from patients who had actually been cared for at their own hospital or healthcare facility. So that's what we're referring to as site-specific patient stories as a key element of implicit bias training. And the themes, these themes that arose in the clinician interviews also really aligned well with the themes that we were hearing in the focus groups with patients, which also really resonate with the themes that Kayla just referenced in terms of patients really expressing a desire to be heard and respected and humanized in their care. So in doing some qualitative data analysis with this subset of the clinician interviews, there were sort of three major themes that we found arising around these recommendations. So when clinicians talked about or recommended that patient stories be included in implicit bias training, they saw or they expressed those as benefiting the training in a couple of ways. So one, they said that patient stories could increase empathy, two, that they could increase acceptance, and three, that they could increase self-reflection. So I'm going to delve just a little bit more into those. And in these three themes, in the analysis, we are sort of understanding them as associated with three tiered levels of accountability. So empathy being related to hearing from patients and direct patient stories of racist and biased care, clinicians felt would enable participants in implicit bias training to connect emotionally with those patient experiences and really engender an acknowledgement that, racist and biased care is happening and how that impacts patient outcomes. So I have some quotations that are on the poster. I'm actually going to share some different quotations, because I know you can download the poster if you're interested in hearing the words from the clinicians. So I'm going to share one quotation in this theme, which is, I really feel like hearing the narrative of the person that's impacted by racism. I think those stories are sometimes more impactful and can create change than any 1 hour little training. So clinicians really talked a lot about the stories from patients enabling like an emotional connection with that reality. The second theme of acceptance, we're associating with the sort of next level of accountability, which is not only does racist care happen and impact patient outcomes negatively, but it happens here at this institution. And in this theme is where clinicians talked, or where the idea of these site-specific stories really arose. So a quotation I'm going to share in this theme is, for example, if we identified 5 people who had been affected by implicit bias, and then those 5 people told their stories, but they didn't have to call the doctor out, and that doctor who had the bias, they would know, oh, that was my patient. So in this theme, clinicians were really calling out the idea that patient stories from one's own hospital could create this understanding and acceptance among clinicians that, racist care is happening, not only in general, but happening here at the facility where I work. And then in the third theme, self-reflection, we saw this as being associated with the sort of highest level of accountability, which is personal accountability, and the ability of patient stories to encourage clinicians to take ownership of biased care that they themselves may be participating in or delivering. So a quotation that I want to share in this theme is, I think patient experience is really helpful for me as a provider. Like having someone up there just lecturing about this is not that impactful. But when you have patient experience and then getting people to really reflect on their personal biases, it's uncomfortable for people. And so I think that speaks to clinicians' feelings that being able to connect with stories from patients that they and their colleagues had cared for would be able to unlock a level of self-reflection that could really, potentially, hopefully engender behavior change. And then lastly, I just want to underscore that, all of these recommendations really did dovetail strongly with patients' desires to be heard and humanized. And there's some really beautiful quotations that we shared on our poster. So I'm just going to share 2 of those. I want my doctor to treat me like a human being. I want to be treated like a person, like I have feelings, like sit down and ask me questions, talk to me, get to know me. And that just came through really strongly in our conversations with patients. And I think there's just a lot of synergy between what patients were telling us they wanted in their perinatal care. And, as Sarah mentioned earlier, implicit bias training isn't the only or the ultimate way to achieve this, but it's, this subset of the data was really compelling in the potential for storytelling in implicit bias training to make positive change.
Thank you for bringing the patient voices into this space. Those quotes were amazing. Questions for Fiona? Go ahead.
I'm so sorry, Fiona, but I just appreciate your storytelling. It brings back to our heritage, where our parents or our grandparents told us stories, and from those stories we grew and had an understanding. And in a way, this storytelling to everybody of experiences lived is a way of growing and understanding and maybe making change. So I just see it as something like from our own heritage, like for me, from our Latina heritage, where grandpa and grandma used to tell us stories, and from there we grew. So I think it seems very similar to me in that way, and it's I love that will make a change, the storytelling.
Yeah, thank you. I think, for those exact reasons, this was really compelling to us when we noticed this in the data, because it wasn't something that had been asked specifically, but the fact that so many people just spontaneously were bringing up the power of storytelling was really inspiring. So thanks for sharing that.
It is incredibly humanizing and brings it so close to home also. All right, we have one more presenter. Our next presenter is Celestine Affori Parku, who will be speaking on racism and discrimination and its impact on health outcomes. Celestine, the stage is yours.
Hi everyone, good morning. I'm Celestine Affori Parku, a second-year doctoral student in the School of Nursing and a graduate research assistant of the UCSF Milk Research Lab. And I'm presenting on the impact of racism and discrimination on health outcomes for pregnant Black women. So despite spending twice the average of its income on healthcare, the US maternal mortality rate is higher among other countries in the global north. And this burden of mortality rate in the US is significantly greater for Black women than for women of any other racial group. And this health disparity is largely attributed to racial discrimination. And the racism as a theme has been found to impact health in several ways. It even diminishes the participation in healthy behaviors and promotes participation in unhealthy behaviors, and even leads to physically motivated violence. So we sought to actually examine the association between Black women's self-reported experience of racism and discrimination during the perinatal period and their self-reported health outcomes, which is hypertension, depressive feelings, and their birth complications. So we conducted a secondary data analysis using chi-square and logistic regression of the contraception, human milk, and research mechanism study. This was an online cross-sectional survey, which was conducted across 22 states in the US. And this study was informed by the life course perspective and reproductive justice. Our study participants were 235. And 214 of our study participants identified as Black or African American women, and 24 of them identified as both Black and Afro-Latinx or multiracial groups. The age of our participants ranged from 20 to 45 years, and 92% of them were Black women. 72% of them had at least college education or above. 74% of them were employed. 69% of them were on private insurance. 87 of them delivered in the hospital, and 70% of them were or practiced human milk feeding. So in doing this analysis, what did we learn? We found out that the rates of hypertension and birth complications were higher among 72 Black women who experienced racism and discrimination during the perinatal period, compared to 163 who did not report the experience of racism and discrimination. We also looked at the association between their self-reported experience of racism and discrimination and depressive feelings. Although this analysis came out not statistically significant. The rate of depressive feeling was slightly higher among Black women who experienced racism and discrimination. That is 76.4% of them, compared to 70.8% of them who did not experience racism and discrimination. And in the logistic regression model, we controlled for factors such as their geographic location, their education level, and employment status. And yet, individuals who experience racism and discrimination had 2.7 times the odds of reporting hypertension and 2.5 times the odds of having birth complications compared to those who did not experience racism and discrimination. So we concluded that our findings suggested that exposure to racism and discrimination during the perinatal period is associated with significant health risks for pregnant Black women and their newborns. But the issue is not about being Black and should not be interpreted as such, but rather it is whether these Black pregnant women experience racism and discrimination that is associated with their odds of perinatal hypertension and birth complication. And even though the rate of the depressive feeling was not significantly different in both groups, whether the women experienced racism and discrimination during the perinatal period or not, it is right for us to see that the rate of depressive feeling in both groups was greater than 70%. So there is a need for us to address maternal mental health. And also, given that 4 out of 5 of these maternal deaths are preventable, it is good that interventions need to focus on addressing systemic and structural racism. So we came out advocating that there is an urgent need to adopt respectful maternity care as an approach to care. And also, the language of respectful maternity care should be included in our maternal health care bills in order to help us help the mothers to reduce this rate, as pregnancy and childbirth are eventous or momentous events in the life of the pregnant women and their family. And it's actually depressing or heartbreaking to get pregnant and then either not go home with your baby or not go home yourself. So we are recommending that respectful maternity care should be an approach to care or should be included in our maternal health care bills. Thank you. And we thank our study participants and our community partners also for their support.
Thank you so much, Celestine. I'm going to open it up for questions. There is one question that came in through the chat. Karishma's not able to ask their question aloud, but they're wondering, they're noting that they're seeing a lot of data about poor maternal outcomes for Black women quite a bit, but not necessarily many strides or directions. So their question is, have there been strides to help with this major issue? Is our institution, NIH, or other major organizations producing guidelines to help with this concerning trend?
Yeah, unfortunately, when you look at the direction in which this mortality rate is going, you would ask, are we going forward or we are actually coming back in terms of reducing the rate? But the rate keeps increasing. It will interest us to know that in 2018, the rate of maternal mortality among Black women was 33.7 per 100,000 live births. It shot up again in 2019 to 44.7 per 100,000 live births, and then shot up again in 2020 to 55 per 100,000 live births. So with all the interventions that people are putting in place, even looking at California, where the maternal mortality rate is lower compared to national average, still mothers are dying.
Questions? Other questions?
I have a question. I'm sorry.
Go ahead. Go ahead, Deborah.
Thank you for this really important work. I just had a question about the measure of discrimination and racism. Was it specifically around their prenatal or birth experience, or was it a more global measure of racism in their life?
Yeah, it's a daily experience, not using like the global measure. Initially, the study started with a validated measure of racism and discrimination, but in collaboration with our community partners, it came out that those things or those measures do not speak to their their personal experience of racism and discrimination, but rather what we had on those skills were like everyday experience. So if we really want to know their personal individual experiences regarding the perinatal period, we had to collaborate with them to ask questions that were tailored towards their personal experiences. So we asked questions like, did you feel that you or your family members were treated differently from other people? Did you see or experience anybody being treated differently? So those were the questions so that they can share their personal experience.
Thank you.
We have 5 minutes left in our session. I was alerted to the fact that I may have missed one of the questions for Fiona. Dr. Asiodo, if you still have a question, I mean, it's actually opening it up to the group. Any questions for any of our 4 wonderful presenters, but particularly wanted to acknowledge that I may have missed one for Fiona earlier from Dr. Asiodu, if you still had a lingering question.
No, thank you. Thank you so much. Good morning, everyone. Such wonderful content that's been shared during this session. I think more of a thought for the entire group. I really appreciated Dr. Miller's presentation. And just a thought in terms of how do we move past providers, staff, anyone who comes in contact with Black birthing people and their families, needing to hear about those, for some, re-traumatizing experiences. There's a lot of data in regard to these lived experiences. And so I'm just curious in terms of at what point do we feel like enough data have been collected, or there are enough stories that can be shared to where we actually move to action versus needing to continue to hear these stories to actually humanize individuals. And so I appreciated the fact, I think, with both of the speakers who presented on the men study, really talking about patients saying they just wanted to be humanized and really wanting people who are engaging with them to see them as humans deserving of just basic human respect. And so it's just a broader question, I think, just to everyone. And I'm a qualitative researcher, so I appreciate and understand the importance and the need, but also am struck with when is enough enough and how do we move past that? Thank you.
Such a critically important point. Do any of the presenters, Sarah, go ahead.
Thank you, Dr. Asiodu. I completely agree. I think it's a great question. And I've been talking with our team about, what are the ethical implications of asking patients to provide more stories of I mean, morally, is that the right thing? So yeah, I mean, I think this analysis that Fiona presented is really interesting, and it also adds more questions to the mix. And I agree. When I started hearing, I conducted the provider interviews, and when I kept hearing people saying, I think there need to be patient stories, I just kept thinking, like, are they not listening to the podcast? Are they not watching the documentaries? Are they not, do they not have friends who are affected by this? And not everyone was saying they needed the stories. They were saying some of their colleagues needed the stories. So I think part of it was this narrative around, there are some people who still don't believe that, like, they themselves are biased or are discriminatory, or like they think our hospital's fine, but other hospitals have a problem. So I think that's something we have to dig more into, whether it's this narrative of other people need this, because obviously it would be hard to recommend this if it's going to traumatize more people. That said, a number of people in our focus groups did say that, like, they would be willing to have their stories shared as examples of things gone wrong at given facilities. And there's still ethical implications of that. We would need to figure out, like, how do you do that in an ethical way that's fair, with compensation and with, like, guardrails to make sure that people don't get hurt. But I do wonder if, there are a lot of questions, and I'd love to hear what other people say as well, but I'm thinking similar things as you.
I'll just really quickly add on to that, because I think this is such an important question. I think that is also one reason why the idea of these stories being site specific was so compelling to us, because I think, there is a lot of stories out there that people can access in all types of different ways, but to really connect that that's happening in one's own environment, and the hospital where you work, in your own clinic, and to hear from patients that you yourself have taken care of. I agree. I think there is a big risk for re-traumatization, and that is not a fair position to put our patients in. Although, I do think also, as Sarah mentioned, the fact that a lot of the patients in our focus groups brought up their willingness to share their own stories is important to recognize. But I think there is sort of this, like, gap between it's, like, happening in general versus it's happening here where I work, that is something that is, like, a little bit, that's an important difference.
So much more to be said on this really important topic. We are right at the hour, unfortunately. I want to give a just big round of applause, appreciation for the presenters. I'm inspired by the work that you're doing, and hopeful. It gave me hope that this work is happening, and also really appreciated the audience participation and just the additional lenses and perspectives in terms of what's happening on the ground and in people's lives. So thank you for participating. Happy Friday. Enjoy your weekends. Take care, everyone.
Thank you, everyone. Please don't forget to send us the survey evaluation. I put it on the chat. Thank you.